let's do this. We going? All right, I'm reading off the list from the top. So the first one, we're gonna stand in the middle, sorry. Valgus stress test for the elbow. Okay, I'm gonna do it on his right side. He can be standing or seated. We're gonna do it standing. I think there is some benefit to having the glenohumeral joint externally rotated because it exposes the elbow a little bit more. So my position, one hand is going to be on the medial side on the ulna. My other hand is going to be on the lateral side of the elbow. Now, although Starkey doesn't describe it this way, I want to keep it consistent with the knee. So I'm going to provide a valgus force first at 0 degrees, then I'm going to do it again at 30 degrees. If you do not externally rotate, you'll sometimes get some internal and external rotation here. So externally rotate, elbow extended at 0, valgus, then you're doing it at 30. Structure you're testing is the UCL. What dictates a positive test is either pain over the UCL or increased laxity compared bilaterally. I think that's everything. All right, moving valgus test. It's kind of like milking a cow. I don't know if you've milked a cow before, but that's how we describe it. So, take one step forward for me. All right, he is standing or seated. I am off to the side. First thing we do is we abduct his shoulder to 90 degrees. Then what I'm going to do is I'm gonna grab his thumb and angle it down, like that's the nipple on a cow's udder, so I'm milking it. I am then going to externally rotate as far as I can. And with this hand here, it's on the lateral side, I'm providing a valgus force. So external rotation, valgus force. Now I'm moving his elbow from a position of flexion to a position of extension. I'm going back and forth. A positive finding here is typically occurring between 60 and 120 degrees of flexion. Now, what the positive findings are is he will describe pain over the UCL, or it's tough to pick up like laxity in this. It's possible that you could do it. Which would mean attenuation or stretching that's going on the medial side. As his elbow is moving into greater flexion, you are most likely testing the posterior bundle of the UCL. As the elbow is closer to extension, you are emphasizing the anterior bundle of the UCL. And so this is much more him describing pain or some apprehension of the test between 70 and 120. Vera stress test. He can be standing or seated. I'm going to turn you like this. I'm once again going to externally rotate just a little bit. Have his elbow all the way extended. One hand is going to be on the medial side of the elbow, other hand is down here by the styloid process. I'm going to provide a varus force both at 0 degrees, then I'm going to do it again at 30 degrees. The structures that I'm testing here are the lateral collateral ligaments, which include the LUCL and the RCL. What dictates a positive test is either pain over those ligaments or increased laxity compared bilaterally. Oh, this is a tough one. All right, posterior lateral rotatory instability, pivot shift test. Let's have you lie supine with your feet down there and your head up here. Emily, I'm gonna have you swing around to this side over here. So this test is identical to the lateral pivot shift in the knee. What we are looking for, as the knee suggests, is posterior lateral instability. So his position for this is that I am going to bring him into shoulder flexion so that his arm is all the way up over his head. Then I'm going to put him in a position of supination. They say it in Starkey, but he's pronated. So one hand, I am grabbing his distal forearm. With the other hand, I'm on the lateral aspect of his elbow. So how to perform the test? I'm giving 3 forces. I'm doing supination, I'm doing valgus, and a little bit of axial loading. So I'm pushing my hips and my body this way. So I provide those 3 forces, supination, valgus, axial loading, and then I'm moving him through flexion and extension. So what dictates a positive test? Typically, as I move into the first 40 degrees of flexion, the head of the radius will sublux, so I'll see it pop out a little bit. And as I move beyond 90 degrees, it's gonna go ahead and reduce itself. So I'm gonna be bringing it back and forth when I'm doing that. You can sit up. So that is a test for posterior lateral rotatory instability. So the structures on the lateral side are RCL and LUCL. If the head of the radius is subluxing, obviously the annular ligament is involved as well. Hook test. All right, you can come back over here. And you can come back. I'm going to do this standing. This can be standing or seated. I'll show you how the book says it first. It's not really necessary, but he's going to abduct his shoulder to 90 degrees, and then I want you to flex your elbow 90 degrees. Just hold it there. You don't have to flex hard. I'm going to put my finger in his cubital fossa, that's right here, and all I'm going to ask him to do is supinate his hand. And when he does that, I can hook my finger right underneath his bicipital tendon. We can also do this in this position. So he starts right there. All he's going to do is supinate, and then I feel the tendon right there. It's just more prominent when he's in that position. So this is for, you can relax, a rupture of the distal tendon of the biceps brachii, and it's one of the rare tests that you have that has a 100% specificity and sensitivity. So if you don't feel it, it's torn, and if you do feel it, it's not torn. That's that one. You don't, the tendon's not there. You can't hook around with your finger. Next one is tennis elbow test. So we'll have you seated for this one. Why don't you come right back here? You're gonna rest your arm up here. So tennis elbow is for lateral epicondylitis. Sit up straight for me, just because I want your elbow at 90 degrees, that's fine. And you can see his hand and wrist is off the end of the table. My position is going to be off to the side. With one hand, I'm going to be palpating the lateral epicondyle. With my other hand, I'm going to be resisting his wrist extension. Sometimes it's a little bit more comfortable to have the person make a fist because it's controlled. You don't have to make a tight fist, just make a fist and you're going to start an flexion. And what I'm going to be doing here, I need him to keep his arm on the table, so I guess I can do it this way as well. I'm going to go ahead and ask him to extend as hard and as far as he can go. Go ahead and extend. So, structure I'm testing are the extensor tendons. What dictates a positive test is exquisite pain underneath my finger on his lateral epicondyle. That's tennis elbow. Golfer's elbow is on the medial side, so although this chair is a little bit low, we're going to use it. Now let's switch to do it the right way. Take this. All right, now you're in a better position, just like that. So now he's relaxed, his forearm is on the table. I'm gonna make sure I have one hand on his medial epicondyle right there. He's going to make that loose fist. He's gonna start in a position of extension, and I'm going to resist the flexion, come all the way through full range of motion. So he's activating, producing tension in his flexors. So this is for medial epicondylitis, and a positive finding is exquisite or a lot of pain over his medial epicondyle. I'm gonna just bring this over here. All right. Next one is valgus and varus tests for the IP joints of the hand. So I'm gonna just demonstrate this on the second PIP joint. So he has collateral ligaments, that's right here. For your test, I would just pick a ligament or pick a test valgus or varus of a particular joint, and you'll have to do it. So let's say I tell you to do the radial collateral ligament of the second PIP joint. That would be right here. So his position, standing or seated, my position, one hand I'm going to stabilize proximal to the joint, so that would be the proximal phalange. The other hand I'm going to be stabilizing the middle phalange. How to perform the test, I'm gonna go ahead and provide a varus force. So a varus force means his finger is bending this way. Positive finding is going to be laxity over the ligament compared bilaterally, or point tenderness over the radiocollateral ligament. Now, if you were confused when I said a varus force is coming from this direction, with the hand, I always advise you to be doing it from the anatomical position. Because if you keep him in this position, you're probably unlikely to be confused that the varus force is coming from this direction that's tugging on the radiocollateral ligament. So if I come up to you and give you the hand like this, you should immediately turn it that way to make your life easier. All right, Phelan's test is the next one. You can do it standing or seated. We're gonna have you seated because I'm seated. Clinician's position will be along the side. Two ways of doing the test. The first way of doing the test is you ask the person to bring the back of their hands together at approximately the level of like their nipple line, that's right here. And you have them press the backs of their hand together, trying to make a 90-90 angle just like that. And you ask them to hold it for 1 minute. It is very important that the person is not shrugging their shoulders, because if he were to be suffering from TOS, he might have a reproduction of symptoms that's not due to carpal tunnel syndrome, but that's due to the shoulder shrug. So as he's holding it, just make sure he's not shrugging his shoulders. So after a minute, you can relax. What we are asking him is if he has the reproduction of symptoms in his hand. And if he has the numbness, the tingling, that is a positive finding for carpal tunnel syndrome. If you think he might be shrugging the shoulders, you can do this test unilaterally by me supporting his forearms so he's not shrugging, and then I'm going ahead and putting him in passive flexion as far as he can go. I don't like doing this because I'm lazy, and then I have to hold him for 1 minute here, and then I have to hold him 1 minute over there. So I prefer him to not shrug and just get it done in one sitting. All right, Tinel sign. Two common places, one in the elbow, one in the wrist. So if we are doing Tinel sign for ulnar neuropathy in the elbow, all I'm doing, Tinel means tapping. I am tapping in between, close so the camera can see, the medial epicondyle, which is right here, and the olecranon process is right here. So I'm just tapping over the ulnar nerve. Positive finding is a reproduction of symptoms that's coming down into the hand. I can also do a Tinel sign in the hand and wrist. That is going to be for the median nerve, most likely the result of carpal tunnel. So in that case, the clinician is tapping over the transverse carpal ligament. Do not get confused and think that the carpal bones are here. They are not. The carpal bones are in here. So where you are tapping is going to be right over here. Positive finding is going to be a reproduction of symptoms into the hand, typically over the thenar eminence where the median nerve innervates. Finkelstein's test. This one is done bilaterally. Patient can be standing or seated. They're going to flex their elbows to 90 degrees, have their hands in front of them. They're going to wrap their thumbs inside a closed fist, and then we are going to ask them to actively ulnar deviate as far as they can go. This is a test for de Quervain's disease, which is a tenosynovitis of your abductor pollicis longus and your extensor pollicis brevis in tunnel 1. You can relax. And it is important to note that this pain can be elicited under normal circumstances. So it's always a good idea to do this bilaterally, because if he's coming into this test complaining of pain on this side, you can use the other side as a benchmark to ensure that the pain is even more significant on the affected side compared to the unaffected side. Watson's test. Scoot over, Emily, just a little bit that way. So this is a test for scapholunate disassociation. His position, scoot back just a little bit. We're gonna pretend we're arm wrestling now, okay? So you're gonna be right there. He's gonna have his elbow on the table, his elbow at 90 degrees. What I am going to do is go ahead and find the palmar side of his scaphoid bone, which is gonna be right here. So I'm gonna go ahead and press on his scaphoid bone and push it in a dorsal direction. So I'm pushing it back. Then what I'm doing is I'm starting him in a position of ulnar deviation and performing the test by moving him into radial deviation. So what normally should happen as he moves from ulnar to radial deviation is his scaphoid should migrate in a palmar direction. But if the scapholunate ligament is lax, what happens when I move him to radial deviation, the scaphoid is gonna clunk or thunk as it moves posteriorly because it's not being connected to the lunate. So I come from here to here, he gets a little click or a clunk. What I can also do, if I go ahead and release my thumb, there may be a second clunk as it attempts to move more in its palmar direction. So the positive finding is the clunk, and it's for a scapholunate disassociation. All right, long bone compression test. You can stay there. This can be done on any long bone. I'm just gonna demonstrate it on the 5th metacarpal. He's in any position, so what I'm doing is I'm going to grasp the proximal and distal end of any long bone. How to perform the test, I'm going to attempt to take the bone ends and squeeze or push them together. A positive finding here is the creation of a false joint, because what I have just done is taken a fractured bone and made it even more fractured by displacing it. In life, that is a big no-no. We do not want to make a condition worse. We want to make it better. So you should never be performing a long bone compression test, yet somehow I get my cheap thrills out of constantly teaching you this test. Wartenberg sign. So last one. I want you to, we'll do it with this hand. We'll do it with both hands. I want you to take both of your hands and put them on the table. So we're gonna say that this side is affected. So the clinician is watching. What we are telling him to do is actively adduct all of his fingers together. So just bring them all together. That would be a normal test. But if I ask him to do it and the pinky stays in its abducted state, that is due to ulnar neuropathy in the hand where it's coming through tunnel Guyan. So that nerve is affected. The reason why the finger stays to the outside is because the radial nerve innervates the abductors, which brings the finger away from the midline. But the ulnar nerve innervates the adductor digiti minimi, which is the muscle that adducts it. So you have the ability to move it away, but you've lost the ability to adduct it, and that's what the finger looks like.